Good morning. This is Bill Storms talking to you on a tape recording. I'm going to talk about chronic cough in adults, not talking about kids. That's a totally different lecture. I've had interest in cough for many years. I had a cough clinic. I also did clinical trials on new drugs for cough. So because of the surgery on my leg, I'm not able to travel or I'd be there with all of you, and I'm sorry. Since this talk is near the end of the morning, I'll try to keep it short. Slides are available to be sent out. All you have to do is contact me, and I'd be happy to send them. You should know that chronic cough is the most common symptom that sends patients to medical care. That's a pretty big deal. Most patients are just given cough suppressants. Then they decide they have to live with the cough because they've been to a few different doctors and the doctor merry-go-round, but realize that we can diagnose them and usually fix their cough. Most chronic cough patients have at least 3, if not 4 different triggers, and they all have to be treated. Can't just treat allergy or sinus or GERD. The bottom line is evaluate all possible triggers for cough and treat all triggers. All the data shows that 80% of cough patients can be cured. So we got to realize that chronic cough has a totally different mechanism than asthma. Cough is caused by a vagal nerve receptors in the throat and airways. It's also affected by the cough center in the brain. And as you know, asthma is a disease of the airway epithelium with mediator release and eosinophils. So the vagal mechanism in cough, first, there's the afferent neural pathway from the vagal receptors in the throat, trachea, all the way, also the esophagus, diaphragm, all the way to the brain. Then the central pathway, the cough center in the brain stem and the pons, and then the efferent pathway goes to the phrenic and spinal motor nerves, sending impulses to the respiratory muscles, and that causes a cough. Here's an example of an airway in the bottom left. The arrow is pointing at the cough receptors, and what happens is the stimulus goes up the vagus through the nodose and jugular nodes and then into the brain, which causes an efferent vagal response causing the cough. Here are the receptors in the epithelium. Across the bottom, we have airway epithelium. The receptors are a whole alphabet of letters, TRPA1, PA2X, EP3, et cetera, et cetera. What stimulates these receptors? Well, smoke, heat, cold, ATP, polys, eosinophils, pepper, lemon, acidic things, and then over on the right, Mr. Mucus from sinus drainage. So looking at the top of the slide, there are many vagal receptors which trigger cough. Once the cough patient has a chronic cough, they have heightened receptors. So they may cough for many other reasons, other factors triggering the cough rather than their primary cough reason. Down here at the bottom, you can see all these C fibers and alpha delta fibers that go into the vagal nerve. So here's an example at the bottom of some of the receptors for the vagal cough receptors. Start at the bottom, the lung, the bronchial tube, trachea, larynx. This does not show the diaphragm and the esophagus, but there are receptors there. So what conditions cause cough? Well, the common ones, the big 3, that's 4, sorry. Rhinitis, allergic and non-allergic, sinus disease, asthma, and GERD. And usually I forget about GERD because most patients, by the time they see us, they've been treated 2 or 3 times for GERD and never help, but it's got to be in that list. So for allergic and non-allergic rhinitis, do skin tests on all cough patients. No question about it. Chronic sinusitis is a possibility. Do a sinus CT on all cough patients. Is it asthma? Do a spirometry before and after bronchodilator in all patients. So we have the tools. Allergists and ENTs have the tools to evaluate rhinitis, sinusitis as the most common causes of chronic cough. Because most patients will have more than one trigger, you have to do all of these. If you just nickel and dime them and say, well, we'll do your skin test today, see how you do, and then I'm going to treat you. Come on back in a month. Okay, well, we're going to do a breathing test. Well, I'm going to give you a little something different. I'll come back in a month. Well, we'll do a CAT scan. Well, by that time, the patient may either have found another doctor or figured out that we don't really know what we're doing. So do everything at once. Well, maybe not on the same day because they may not be able to have their skin test, but within a very short period of time, tell the patient we're doing all this. Now, when you take a history, you do the standard HPI, ask about the onset of cough, duration, aggravating factors, previous treatment, previous test, x-rays, etc. Most of these patients have had a cough for a long time. The typical patient is female in the 40 to 55 age range, but there are plenty of men with chronic cough. These people will come in and they say, I'm here because my coworkers said I always have a cold, I'm coughing all the time, I have to see somebody. I saw my family doctor, I saw an ENT, I saw a GI doctor, and I still have a cough. Well, they probably were just treated for the one thing that specialist treats. Second bullet, obviously, ask about ACE inhibitors. And by the way, ACE inhibitor cough may continue months after the ACE is stopped. Physical exam in most cough patients will be normal, except you may see evidence of allergy, such as swollen turbinates, pale turbinates, maybe polyps, postnasal drip, tender sinuses. You may hear wheezing, but I doubt it because those patients pretty much know they have asthma already. So remember the three major things for cough, the diagnostic triad, so to speak: asthma, postnasal drip, and GERD. So as I mentioned, I do all of these on every chronic cough patient. Skin test, spirometry, sinus CAT scan, then chest x-ray if it's not done recently. 90% of the time it's going to be normal, but in that 10%, when you find a large nodule, that's a very important 10%. So you do all these tests, then you say, okay, you've got sinus problems, you've got some allergy, your breathing is normal, so we're going to treat you for allergic rhinitis, chronic sinus disease. You can also treat for GERD empirically if you like. Then see them back in a month or two and see how they're doing. So here's a patient, real patient. Cough patient comes in. His only symptom was nasal congestion and postnasal drip. Never had sinus infections, didn't have pain. And Chris Thompson has explained this to us. These people have asymptomatic sinus disease. Well, I guess it's symptomatic. They have postnasal drip, but they don't have the typical symptoms you would expect. And they don't have 6 antibiotics a year. They've just got a lot of junk in their sinuses. And this patient had a cough. Actually, it was a female, sorry. She had a cough for at least 10 years. I treated her with sinus rinse, nasal steroids. She had some allergy, had her on antihistamine, antibiotic, cough was gone. A few years later, maybe 2 years, she came back. She said, oh, my cough is back. Got the CAT scan. It wasn't this bad, but do the same thing again. She was fine. So how about GERD? Well, There's no real great test for GERD. There have been a lot of studies. All these complex tests of esophageal reflux, pH, impedance, scoping are very poorly predictive of a response. Therefore, treat empirically, at least 8 weeks with a good PPI, nice strong dose. How about nasal steroids? Here's a study of allergic rhinitis patients and 245 patients treated with mometasone, 14 days. You see on the right, they looked at all these different symptoms, typical for allergic rhinitis, but they also looked at cough, which I've circled, and you see P less than 0.05 versus placebo. The mometasone improved their cough. So why does it improve cough? I think it's probably because of the postnasal drip. So that would be helpful for non-allergic rhinitis, chronic sinusitis, and allergic rhinitis. What about singular montelukast? Small study, but here you see this is the LCQ, it's the Leicester Cough Questionnaire, which is the standard cough questionnaire used. And it shows before and after significant improvement in cough with P less than 0.001. So one of the reasons singular montelukast is helpful is that the cough receptor when it's stimulated, there's ATP that's released and there's a release of leukotrienes. So I always add singular to the antihistamine. So treating the patient with chronic cough, obviously, figure out what their triggers are, and then treat them all. If they have rhinitis, give them everything. Nasal steroids, antihistamine, singular, sinus rinses, and when their cough is better, get them on Skit, Slit, or Exact. If they have chronic sinus disease, antibiotics, sinus rinses, possibly IOP surgery, depending upon what their CAT scan looks like. Asthma, obviously, ICS-LABA, and avoid narcotics, GERD treatment trial, and then reevaluate and consider the differential diagnosis. If the cough persists, they may have cough hypersensitivity syndrome. So this is also called chronic undifferentiated cough, idiopathic cough, refractory cough. It's not common, but if you've treated all these other things, they're still coughing, then you have to do empiric treatment, trial and error. Number one, small sips of water frequently, cough lozenges, non-menthol, just honey or something like that. There are a variety of drugs that can be tried, chlorpheniramine, work up to 12 milligrams BID. Spiriva may work, might not work. Pregabalin, increase from 75 BID over 3 to 4 weeks to 150. Gabapentin, start slow, move up. Obviously, you have to know all the side effects. They've got drowsiness, dizziness. Amitriptyline, again, try that. Ditropan, well, I rarely use that because if you have a male or even a male with a prostate or a female with any urinary issues, that can really mess them up. Same thing with methylscopolamine and speech therapy. But these are the people who you treated for the other issues and they're still having the chronic cough. Sometimes you even consider referring them to pulmonary, last ditch effort, but they would get a CAT scan, they might do a few other things. There are a number of drugs in development. None of these have made the market. The big one Merck had, they paid $150 million, I think, for this, or maybe it was one billion, whatever, but they canceled the study. There are a couple other ones that may be coming out. So what if your patient is still coughing? Hopefully you'll get things all figured out. You won't have to worry about this, but if you do, just keep this in the back of your, or print this out somewhere, put it on your computer, consider cardiac issues, PVCs, obstructive sleep apnea, ask about their sleep, chronic interstitial lung disease, other pulmonary diseases. So at some point, you may want to do a CAT scan. Bronchiectasis, pertussis, bronchiomalacia, sarcoid, TB. I mean, these are so rare. Carcinoma, that's why chest x-ray is really good early on. So, to summarize, chronic cough is a common problem which is inadequately treated. There are multiple triggers for people's cough: allergic rhinitis, non-allergic rhinitis, GERD, postnasal drip, sinusitis, asthma. Identify all the triggers, do all the tests, treat all the triggers, and I think you'll have some very happy patients. So I thank you very much and hope you have a good rest of the day.